Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We would greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Hey everyone, Chris here from MedPrep2Go, and welcome to another episode of our USMLE Step 2 Questions podcast. In this episode, I'll be reading 3 more Hem-Onc questions from our online Qbank, and of course you can read these questions and more at medprep2go.com. And now, let's get started with question 1, Hem-Onc 8. A 27-year-old woman presents to her physician with complaints of fatigue lasting over a year. She first noticed the fatigue following the birth of her second child, although both pregnancies were uncomplicated. She was informed during each pregnancy that she had anemia. Past medical history is otherwise unremarkable, and she does not take any medications. Vital signs are within normal limits. On physical examination, no abnormalities are noted. Laboratory findings are as follows. Hemoglobin 11.6, mean corpuscular volume 66, and reticulocyte count of 0.3%. Hemoglobin electrophoresis results reveal the following. Hemoglobin A2, 5%. Reference range 2 to 4%. And hemoglobin F, 2%. Reference range 0 to 2%. Which of the following is the most likely diagnosis? Is it A, beta thalassemia trait, B, iron deficiency anemia, C, lead poisoning, D, sickle cell disease, or E, sideroblastic anemia? And the correct answer is A, beta thalassemia trait. Anemia can be classified based on the mean corpuscular volume into microcytic, normocytic, or macrocytic categories. Microcytic anemia, MCV less than 80, has common causes that include iron deficiency, anemia of chronic disease, thalassemia, and sideroblastic anemia. This patient's low MCV and mild anemia suggests microcytic process, with the elevated fraction of hemoglobin A2 being characteristic of beta thalassemia trait. Answer choice B, iron deficiency anemia, is incorrect. While iron deficiency anemia can cause microcytosis, it is not typically associated with increased levels of hemoglobin A2. Iron deficiency anemia is associated with decreased ferritin and decreased transferrin saturation. Answer choice C, lead poisoning, is incorrect. Lead poisoning can lead to microcytic anemia, but it does not cause elevated hemoglobin A2 levels. Answer choice D, sickle cell disease, is incorrect. Sickle cell disease usually presents with normocytic or mildly macrocytic anemia and would not be associated with elevated hemoglobin A2. Answer choice E, sideroblastic anemia, is incorrect. Sideroblastic anemia can present as microcytic anemia, but it is not associated with increased hemoglobin A2 levels and often shows ringed sideroblasts on bone marrow examination. Key learning point. Beta thalassemia trait is characterized by a microcytic anemia with a mild increase in hemoglobin A2 on hemoglobin electrophoresis, which distinguishes it from other causes of microcytic anemia, such as iron deficiency and chronic disease. Question 2, Hem-Onc 9. A 34-year-old woman presents to her physician with complaints of fatigue for the past 3 weeks. She reports heavy menstrual periods over the past several months, requiring her to change pads every hour during the first 2 days of her cycle. Her past medical history is significant for hypothyroidism, for which she takes levothyroxine. Her vital signs are as follows. Temperature of 37 degrees Celsius, or 98.6 degrees Fahrenheit, heart rate 102 beats per minute, blood pressure of 110/70, and respirations of 16 per minute. Physical examination reveals pale conjunctiva and mild tachycardia, but no hepatosplenomegaly or lymphadenopathy. Laboratory results reveal the following. Hemoglobin 9.5, MCV 72, serum iron 25, ferritin 10, total iron binding capacity 450, transferrin saturation 5%. Which of the following is the most likely diagnosis? Is it A, anemia of chronic disease, B, iron deficiency anemia, C, sideroblastic anemia, D, thalassemia minor, or E, vitamin B12 deficiency? And the correct answer is B, iron deficiency anemia. Iron deficiency anemia is a microcytic anemia characterized by low iron and low ferritin levels, elevated total iron binding capacity, and low TIBC saturation, also known as transferrin saturation. This patient's laboratory findings are consistent with iron deficiency anemia, likely due to chronic blood loss from heavy menstrual periods. The presence of pale conjunctiva and mild tachycardia further support the diagnosis of anemia. Answer choice A, anemia of chronic disease, is incorrect. Anemia of chronic disease typically presents with normal or elevated ferritin levels and low TIBC, which are not seen in this patient. Answer choice C, sideroblastic anemia, is incorrect. Sideroblastic anemia is characterized by ringed sideroblasts in the bone marrow and does not typically present with low ferritin and elevated TIBC. Answer choice D, thalassemia minor, is incorrect. Thalassemia minor is a microcytic anemia, but typically presents with normal iron studies and is often associated with a family history of thalassemia. Answer choice E, vitamin B12 deficiency, is incorrect. Vitamin B12 deficiency typically causes macrocytic anemia, not microcytic. Key learning point: iron deficiency anemia is a microcytic anemia characterized by low iron and low ferritin levels, elevated total iron binding capacity, TIBC, and low TIBC saturation, also known as transferrin saturation. Question 3, Hem-Onc 10. A 65-year-old man presents to the clinic with complaints of fatigue, difficulty walking, and memory problems that have been progressively worsening over the past 6 months. He also reports numbness and tingling in his hands and feet. His past medical history is significant for type 2 diabetes, which is managed with metformin. He lives alone and has a history of alcohol use, consuming approximately 3 to 4 drinks per day for the past 20 years. His vital signs are 36.9 degrees Celsius, or 98.4 degrees Fahrenheit, heart rate of 88 beats per minute, blood pressure 130/78, and respirations of 16 per minute. Neurological examination reveals decreased vibration and position sense in his lower extremities, and his gait is ataxic. Laboratory tests reveal a hemoglobin A1C of 6.8% and a hemoglobin level of 10.2 and a mean corpuscular volume of 110. Further testing shows elevated methylmalonic acid and homocysteine levels. Which of the following is the most likely diagnosis? Is it A, folate deficiency, B, iron deficiency anemia, C, sideroblastic anemia, D, thalassemia minor, or E, vitamin B12 deficiency? And the correct answer is E, vitamin B12 deficiency. Vitamin B12 deficiency presents with megaloblastic anemia and characteristic neurologic symptoms, including peripheral neuropathy, loss of position and vibration sense, ataxia, memory impairment, and subacute combined degeneration of the spinal cord. Elevated methylmalonic acid and homocysteine levels are diagnostic markers for vitamin B12 deficiency. The patient's symptoms, laboratory findings, and elevated methylmalonic acid and homocysteine levels are consistent with vitamin B12 deficiency. His history of alcohol use may contribute to nutritional deficiencies, including vitamin B12 deficiency. Answer choice A, folate deficiency, is incorrect. While folate deficiency can also cause megaloblastic anemia, it does not typically cause neurological symptoms or elevated methylmalonic acid levels. Answer choice B, iron deficiency anemia, is incorrect. Iron deficiency anemia presents as microcytic anemia, not megaloblastic anemia, and does not cause neurological symptoms. Answer choice C, sideroblastic anemia, is incorrect. Sideroblastic anemia is a microcytic anemia and does not present with elevated methylmalonic acid or neurological symptoms. Answer choice D, thalassemia minor, is incorrect. Thalassemia minor is a microcytic anemia and does not cause elevated methylmalonic acid or neurological symptoms. Key learning point: Vitamin B12 deficiency presents with megaloblastic anemia and neurological symptoms, with elevated methylmalonic acid and homocysteine levels serving as diagnostic markers. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 2 questions at medprep2go.com. Happy studying! Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai in her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Hey everyone, Chris here from MedPrep2Go, and I wanted to tell you about our MedPrep2Go Step 3 review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com.